All right, this week we're going over malignant melanoma and a new chemotherapy that isn't really a traditional chemotherapy at all, but is like a cell-based therapy that recently got approved to treat malignant melanoma. So I thought it made the most sense to go back and do just a little bit of background physiology on what melanoma is compared to other kinds of skin cancers, just to give some context. So this is histology microscope image of skin, and everything that you're seeing on here starting at this border. So this is the border between the epidermis and the dermis. So the way this works is epidermal cells come in a few different varieties. The majority of the cells that you're seeing in here, we zoom in close, this layer down here at the bottom are called basal cells. And these are effectively stem cells that are going to divide. So if you imagine this cell dividing into two daughter cells, just going through cell division like any dividing cell does, half of them are going to start migrating up this way, and the other half of them are going to turn around and stay a stem cell because we have to maintain that stem cell population so we don't run out. Because the process is those cells are going to migrate further and further up the epidermis. They're eventually going to start flatten out and pack themselves full of a protein called keratin. And by the time you get up here, these cells that look completely clear, they're not really even cells at all. They're not living. The membrane's still there, so we can see it when it's stained. But they're basically just dead shells of cells that are packed full of that keratin protein. That becomes the surface of the epidermis, which in a lot of ways is a good thing because it gives you kind of a dead barrier on the surface of the skin, prevents infection, all good things. All right. Everything down here is the dermis. That's mostly a lot of connective tissue and blood vessels. And so that border, like for context, if somebody gets a blister where they get like a little pocket of fluid underneath a portion of skin that rubbed like on a bad shoe or on a tool that you're using repetitively, a blister is just separation of the epidermis from the dermis. The two tissues peel apart. The space fills with fluid. All the types of cancer that we're talking about, including melanoma, are in the cells of the epidermis. There's really not a whole lot of cell division in the dermis because it's stable. It's only the epidermis where these cells die off, right? The keratin eventually dies, sloughs off. That's why we have to have this constant generation of new cells dividing from the basal layer and going up towards the surface. All right, so illustration now. So this is same thing as before. This is that borderline between dermis and epidermis, and there are three major types of skin cancer. Basal cell carcinoma gets their name because they started from those basal cells, right, the stem cells at the bottom of the epidermis, and divided and spread from there. Squamous cells get their name, these sort of flat pancake-shaped cells near the surface. They're called stratified squamous epithelial cells. So these are just cancers that come from dividing cells after they've left the basal layer and are migrating up through the more superficial layers. And then melanoma, completely different cell type altogether. So melanoma is cancer of melanocytes, which they're drawing them this darker brown color because those are the cells that produce melanin, which gives skin pigment. So when someone goes into the sun and gets hit with UV light, it's melanocytes that are making melanin to give them more skin pigment, make their skin darker, because melanin is protective, right? It protects against UV light, and so it's really resisting getting sunburned again the next time. Okay, so we have these three different types of cancer. They have different origins. They also have dramatically different outcomes. Squamous cell carcinoma tends to be a relatively minor inconvenience as far as cancers go, typically just surgically removed, like go into a hospital, have them cut out that particular patch of skin, slap a bandage on it, and you're on with your life, and almost always everything's fine. Very, very rarely metastasizes. Basal cell carcinoma, generally not that bad as long as you catch it fairly early on. Again, usually just surgery, relatively unlikely to metastasize, but it is possible. Melanoma, by far the worst diagnosis, by far the most dangerous, and the most likely to metastasize. The cells are just more likely to divide and more likely to break free. And so that is exactly what this is showing, these cells starting to detach and spread. And especially if any of them make it into blood supply, they can, in theory, spread to any other part of the body because they're off and roaming now. And if they have the ability to adhere, right, to stick in another organ, that really defines malignant melanoma. And that's when prognosis starts to look pretty bleak. So these patients, especially ones that have gone through a first round of treatment and it was ineffective, the outcomes are really, really poor, and treatments are limited. So trying to find new therapies, especially for those that primary therapy didn't work, try to give them a second option to try to clear the tumor. Okay, so little background. The drug that we're looking at, Lifileucel, is interesting in that it's not really a traditional drug in any meaningful way. It actually involves just using the patient's own immune system in an amplified kind of sense. So as a reminder, there are white blood cells, right, immune system cells that target tumors. And it doesn't mean they're perfect, but everyone has cells that pop up that easily could have become tumors that were trending that direction that got killed off by cells in the immune system. And the primary actors here are a few different cell types. One is these natural killer cells, which get their name because they kill off human cells that just look unhealthy. Cells that have metabolic problems, DNA damage, something about them doesn't look right. Their membranes start expressing proteins that aren't normal. They'll be killed by natural killer cells. You also have killer T cells. That's these CD8 positive T cells, shown in green. Those are part of the adaptive immune system, and they look for more specific things, right? So in this graphic, this is showing the T cell receptor very specifically binding an antigen on the surface of these cancer cells and recognizing it as something foreign. And I know that sounds odd because cancer isn't truly foreign, but if it has genetic mutations that get copied into protein, those proteins look just a little bit different enough from normal human proteins on other cells that those CD8 positive T cells now have a target. They know what to go after, and they start releasing these molecules called granzyme and perforin that basically break holes in the membrane of the tumor cells and kill them, start breaking them down. And this is the perfect drug, right? If you can somehow harness the power of these T cells, then you don't have to worry about the horrible off-target effects of chemotherapy drugs because there really is no drug. The immune system has a particular target, and as long as it's cancer-specific, that's a very, very powerful tool. Right. The problem with this is, like anything, cancer cells evolve mechanisms of resistance very quickly. So if those tumor cells start secreting molecules like TGF-beta and interleukin-10 and expressing PD-L1, which I know we've talked about, these are basically immune system inhibitors, right? Molecules that the tumor starts producing just by random chance. It's not like tumor cells are smart and they know, oh, I have to start making PD-L1 now. The tumor cells that happen to make those molecules thrive because they avoid being killed by natural killers and cytotoxic T cells, right? And so tumors can't decide to express anything. It's just that the ones that didn't express these molecules already died because they were successfully cleared out by the immune system. All right. So for the ones that are still sensitive, the goal of this drug is exploit this mechanism, ramp up the CD8 T cell response in these patients to try to clear out more of those cancer cells. All right. So the strategy works something like this. We're effectively using the patient's own T cells, right? They're calling this TIL for tumor infiltrating lymphocytes. This graphic was made for a more general audience. These are CD8 positive T cells that were taken out of the patient, right, and exposed to a variety of different targets, right? The goal of this is we want polyclonal TIL cells. Polyclonal meaning they recognize multiple targets, right? This tumor, we assume, has multiple proteins that are mutated because, like we've talked about before, cancer cells aren't homogeneous. It's not like you have a ball of 1,000,000 cells and they're all exactly the same. They develop new mutations as we go. And so in order to do this, we're going to have to expose those T cells that we take out of the patient to the tumor to effectively program them to go after the neoantigens, right, the novel, new, mutated antigens in the tumor so that they know what their target is. And then we expand those T cells, grow more of them, put them back in the patient. You can't control where they go, but since we've trained the T cells to look for the specific neoantigens in the tumor, we expect that they'll go through circulation, they'll leave the blood vessel, enter the tissue where the tumor is, recognize an antigen on its cell surface, and start releasing all of those, granzyme and perforin molecules to kill the tumor cell. And we hope tumor volume significantly goes down if the T cells are good enough at recognizing those antigens that they recognize something on all of the tumor cells. Then you can get complete clearance. But at this point, that's still a pretty big if. Okay, so in a little bit more, scientific detail now, part one of this, as much of the tumor as possible is cut out surgically, and the entire purpose of that is to have some antigens to expose to our lymphocytes. All right, so we're going to take those tumor cells, we are going to expose those to these TILs, tumor infiltrating lymphocytes, which is perfect, right? Cutting out the tumor got us both things. It got us the cancer cells that contain the antigens, and it got us the T lymphocytes that were already in the tumor that were trying to kill it, but just, maybe weren't being quite as successful because remember, tumors that are really good at avoiding the immune system secrete all of these inhibitory molecules that try to shut off T cell expansion. Okay, so now that we've got them in a lab session or a lab setting, they're exposed to the antigen because we're mixing them with tumor cells that we cut out of the biopsy. And we can start adding growth factors like interleukin 2 is a stimulant, like a growth factor, that triggers cell division and production of more T cells. Right? So now you've got this great environment in a lab where you have T cells and cancer cells, and you can add whatever growth factors you feel like, right? And you can inhibit whatever immune system inhibitors you don't want, right? So that these cells are free to grow. And we start off with a relatively tiny population of tumor cells that, with this cocktail of growth factors, gets expanded in a culture dish in a lab to the point where you now have many, many, many times dramatically higher numbers of infiltrating T cells than you did before, right? So we're effectively like cloning and training this army of T cells to specifically go after this tumor, because for every individual patient, right, it is, sort of tailor-made from their tumor, and we don't even have to genetically engineer the T cells. We just incubate them with the cancer cells that came out of the patient and let them learn for themselves what they're supposed to go after, right? Then we put the T cells back in the patient. We give them a dose of that interleukin 2 to try to further stimulate the T cells to grow and divide once they're back in the patient's body, with the hope that they'll recognize those same antigens that were in the biopsied tissue once they're in the actual patient, right? And go after their target, right? Just like we thought they would. Okay. So, background on this. The most historical data that I could pull up on this seems like this thing really got the fast track. So it's kind of an interesting case study. Drug started off in kind of a combo phase 1, phase 2 trial. They effectively got a little bit of a pass on a true phase 1 trial because they were deemed, the treatment was deemed very safe, I think, from the beginning, because we were giving the patient really just expanded populations of their own T cells, right? They weren't from another donor. They weren't genetically modified. They weren't from an animal. They were actual human cells from that exact patient. And so there's no risk of, immune issues because they came from the patient. And there's no actual drug being given. So they jumped straight into a phase 2 trial. And very specifically, they were testing this out on patients that had already had therapy to treat their tumor once, and they had failed it. So these were advanced melanoma patients, like stage 3, stage 4 melanoma, without the drug. Very, very terrible prognosis. No real treatments that are shown to be effective. And so I'm kind of at the point of anything helps, right? And interestingly, most of these patients had their previous therapy that they had failed were actually PD-1 or PD-L1 inhibitors, which are topics we've covered in the past. So they already tried PD-1, PD-L1 immune checkpoint therapy. That failed at some point. Tumor came back. Okay, now we're going to try to just amp up these T cells and see if that does the trick. Okay, so patient characteristics, I put this in here just to give an idea. Sample size was moderate, right? 66 isn't anything terrible, but it's not a gigantic sample size. But if the results are dramatic, then should easily give statistically significant results. Okay, so we break them down by mean number of prior therapies, meaning how many different other treatments had they tried. And so on average, these people had tried 3.3 other types of chemotherapy or radiation. All of them had used either an anti-PD-1 or PD-L1. CTLA4 is another immune checkpoint inhibitor. That was common. These BRAF and MEK inhibitors we haven't really talked about, also common. Interleukin-2, surgeries, radiotherapy. So basically, these patients had really been through a gauntlet of many, many different treatments, and their cancer was still coming back. Okay, so carrying that forward, they're going to try to look at, okay, which of these patients are most responsive. All right, and this is the spread. Okay, so this key is basically a matter of like how bad things are. So patient number on the X, change from baseline, meaning tumor growth. PD is progressive disease. These were the unfortunate patients that actually kept getting worse despite getting the treatment. SD is stable disease, meaning they're not really getting better, they're not getting worse, they're staying pretty close to baseline. Partial recovery, right? There's improvement, but it's not complete. Complete recovery, tumor's completely gone. And you can see from the numbers, there's a decent amount that saw quite a bit of benefit. It is also proving the point that it is incredibly difficult to get rid of 100% of a tumor. A few patients pulled it off, but nowhere near a majority, really only a couple. Now, some of these, if the treatment continues or if they add another therapy on top of it, maybe they'll get there eventually. But at the time of this data collection, more than half saw a large benefit, but only a pretty small number were completely cured effectively. But promising enough and early enough in the research stage that improving the therapy probably has the promise of getting some of these patients down further to also hit the complete removal target. All right, with any drug, especially when you're in phase 1, phase 2, it's not just about efficacy, it's also about unwanted side effects. So these AEs are just showing you unwanted, right, alternative, like effects that you're not interested in, things that are negative. We can grade them 1 through 5, with 1 being something very minor, like a rash or a little bit of nausea, and grade 5 being like really severe, life-threatening sort of complications. And this is time from dose. So day 0, day 14, month 1, month 2, and sort of proves the point that after giving the T-cell, there were a decent number of fairly low-level adverse effects, but nothing major. I don't see a single one that was grade 5, very, very few that were grade 4. But there's something there because we're stimulating the immune system. and stimulating the immune system causes inflammation. And so just probably the inflammatory response of having that many T cells flooded in the body for the first week especially is going to give these patients probably some uncomfortable symptoms. There's a bit of a war being fought inside their body, and their immune system isn't going to let them feel incredibly comfortable about it. But after those first 2 weeks, in the months that follow, they taper off almost zero. And so a little bit of a hit in the beginning because of the inflammatory response. But long-term effects, this is much, much better than typical chemo where you would have to keep dosing over and over again. This is more of a one-time burst of T cells. And those T cells hopefully should stay alive and keep fighting the tumor for months after they were initially injected. All right. Okay, so phase 2 results were incredibly strong. And what ended up happening is this is, part of the purpose of this was to discuss clinical trial sort of process and procedure and politics. Usually you have to complete a phase 3 trial before you get approval. There are workarounds, though. In this case, this drug is in phase 3 right now. This is the clinicaltrials.gov page for the U.S. Recruiting, they're hoping for 670 randomized patients into a phase 3 trial. But very interestingly, this drug actually got early stage, express approval from the FDA. So basically, they got approval to give it to any melanoma patient as first-line therapy, even though they hadn't completed the phase 3 trial. So this is kind of the same thing that happened with the COVID vaccine. The drug is effectively being given like a tentative, rushed approval because the results from the phase 2 trial were so strong and the negative outcomes, the adverse effects, were relatively low. And so they're basically saying, you can give this to as many patients as you want, and we're sort of monitoring that as the phase 3 trial progresses. And of course, if something horrible came about and with a larger sample size, they detected adverse effects that they hadn't before, it's not that approval can't be revoked, but it's hard to imagine a side effect that's worse than dying from malignant melanoma. And so we assume, with how strong the data were, that this is kind of a formality at this point. And the vast majority of drugs that get this sort of rushed approval keep that approval and eventually get a final stamp. All right, so obviously this is still in process. The data from this haven't even been collected yet, and so there's no publication. But we expect a phase 3 trial to probably be completed over the next several years because, unfortunately, like the control group, if there was one for advanced malignant melanoma, those people don't live that long. So it really only takes about a year or two to get very, very solid data on efficacy. And this bigger sample size should hopefully confirm what was seen in the phase 2, that it's effective. And this is a therapy that's not a single molecule, so it can evolve. I'm sure advances will be made in how the T cells are stimulated, maybe what the dose is, maybe get repeated, exposures, and hopefully get even improved results over time. All right, as always, hope you found it interesting and enjoy.